Yes, all right. Real quick, I'd like to thank DLAP for having me. It's always a pleasure to come to this show, especially last year, because they were the only one having a show. So it's good to see everybody. It's good to see everyone again here. Thank you all for being here. Besides dental technology, my background's business and economics, and I look at it as every decision we make, everyone has an opportunity cost or a trade-off. So for your time being here, you could be doing something else. So I appreciate everyone that came into this room today. Hopefully it'll be a little bit fun, hopefully a little bit exciting. Last thing, I do not claim to be a professional on stage. I have not been on stage giving any type of speech, lecture, presentation since 6th grade. So again, please, if anyone has the urge to come up here and give me a Will Smith treatment, please hold it till afterwards, please. Last order of business really quick disclaimer, I am an employee of Preat. So with that, we could get rolling on it and find out why we're in this room today. And like always, I never turn the clicker on. So why are we here today? We're here today so Maggie over here can smile, right? Got to make some dentures. Actually, we're here today so Maggie does not get another denture. So we're going to talk about a whole bunch of different patients and different treatment options so Maggie doesn't find another chew toy. So why is this course important? Well, this course is important because there are a lot of missing teeth in the United States. In fact, 33% of adults over 65 are missing a tooth or many teeth. And the population is only aging right now. So we're going to see a larger percentage of patients that we can treat with implants or edentulous patients. That was not me. It's going to happen over and over. They warned me about it. Somebody's really excited, so, oh, there it goes again. So U.S. population, 65 and older. As we can see, it's growing by percentage and numbers. And so 6% of all edentulous patients have implants currently. But there's a potential 38 million more patients that can have implants placed that will help them in many different ways, especially from a restorative side. So when we take a look at relative functional capacity of the edentulous patient, or any patient, with all our natural teeth, we have 100% functional capacity. Okay? With the no teeth, we have 0 functional capacity. You get a lower denture, that's 10% restored functional capacity. Upper denture, 30% functional capacity. If we go to the implant overdenture, a couple of implants, a couple of attachments, we could get up to 60%. And if we do a fixed or implant-borne bridge, we could get patients back up to 90% functional capacity. And that's where we're going to focus today, is that 90% functional capacity. Interesting trend, we talked about the aging population, people missing teeth, percentages. There are more than 5 million implants placed every year. This is driven by the aging baby boomer generation and also Gen X, which I don't know where I land. We were having this discussion yesterday. I think I'm borderline millennial, Gen X, but and this number's only going to increase. It's going to be about 200 million during the next 15 years of how many implants are going to be placed. It's a lot of restorative work that's going to be needed for these patients. So to me, that sounds like an opportunity. It's a great opportunity right now to be a dental technician. Talk about the patients, this happy fella here. So when I first got into removable and then fixed work, I started reading some old books. In fact, I took this job at Preat about 14 years ago, had no idea what removable even meant. So when I started reading, I found out the psychological concerns patients have around tooth loss. So this happy gentleman here has a lot of pride in that last remaining tooth, because people, when they lose something, they believe they can never get it back, especially when it comes to teeth. And that's where our opportunity is. We have the opportunity in this industry to give somebody something they never thought they would have again in their life. We are changing somebody's life every day, every case pan, every model poured. It's a great opportunity. So, edentulous patient presents. Let's talk about the client perspective when they're looking at this, when this is a situation they're experienced. So, we are providing these patients with their third dentition, from deciduous to permanent to now prosthetic. We're changing people's lives via high quality dentistry. So the very first time I went chairside, it was quite an experience. It was for a local doctor. We at Preat had milled a bar that another laboratory then processed the denture, teeth, and acrylic to. And the dentist called me. She was up the street, and the bar wasn't seating. She couldn't get it down in the mouth. And it's about 4:30. Has to be 4:30. I'm a big baseball guy, so I was going to go coach my kids. I had practice lined up. Had to call off practice because I had to run down and figure out what was going on. And the backstory was I was already sweating and nervous because I had screwed up this bar already once. This was a remake case that has been delayed on my end, and now doctor can't seat it in the mouth. So the doctor calls me, race down, and I'm sitting in the operatory. No idea what's going on, never even been in there. And she's telling me she can't get one of the screws down, the final screw to seat on this fixed case. So I sit there and I look at it. I have no idea why I won't. So she decides, I ask her, does it fit the model? Because I know the bar did. So I said, does it fit the model? She takes it out, she tries it on the model, she can't get the same screw down. So I notice that one of the denture teeth with the screw access channels wasn't adjusted enough to get the driver all the way down to thread the screw in. It was interfering with the driver position. So she adjusts the tooth. We seat it on the model. She puts it back in the patient's mouth. Everything works out. And at that time, I had no idea the impact that the work done in the laboratory, how it impacts somebody's life. So at that moment, when she seated the restoration, patient starts bawling. Never seen this before. This guy just wanted to eat a hamburger again. And he started bawling, and at that moment, that's when I knew that what we do, whether at Preat, in the laboratory, in the office, the impact that it has on somebody's life. So that's where I believe we are fully changing somebody's life all the time. People want their teeth to look, feel, and act like natural teeth. They want teeth that are fixed. They don't want to wear dentures. They want their teeth now, and they want their lives changed now. Talk about some of these people that we'll treat with fixed work. Maybe they were wearing a denture. 34% of patients with dentures claim it limits their ability to live life to the fullest. 56% say it impacts their love life. And 24% are afraid to kiss their partner passionately. So I'll be honest, I love being here with all of you. I really enjoy it. I have a great time, but I get super homesick when I'm on the road. So Saturday, I'm catching a flight, I'm going home, I'm driving home, I'm gonna open that door, and the first thing I'm gonna do, I'm gonna hug my wife and give her a big kiss. I can't imagine what it would be like to not wanna do that. So that's what we're working with. That's what we're changing. 63% of people with dentures kept them a secret. I know two people very close to me that have dentures. One's my mother-in-law, which I try not to talk badly about, but I'll talk about her a little bit later. The other one is, I guess I could sum it up as my stepmother-in-law. It's It's my wife's stepmother. So I had known her about 8 years. She knew I was in the dental field. She knew I worked with dental implants and dentures. And she never once told me she had dentures. I always kind of figured, but whoever did them did some good work. Because I could never quite tell, and I'm not going to say, do you have dentures? It's kind of rude, right? So, but one day we finally had enough drinks in her, and she pulled out her dentures and showed me. She's like, do you think you guys could do anything with this? I said, well, we'll try. So, but she kept them a secret for all those years, and she had to have liquid courage to let me know she had dentures. That's crazy. That sucks, honestly. People say it affects their careers. 1/3 of people lack confidence in meetings. Some don't even go to job interviews. I don't know about you guys, but we're looking for people right now. I don't care if you have a denture. What about bone loss? And how that changes appearance over time. 75% of denture wearers would have chosen an implant treatment had they known about bone loss. Why implants? This came from a recent study. 80% of patients are not happy with the fit or function of a lower conventional denture. Compared to 80% of respondents with implants are happy with their lower prosthesis. So let's take those patients with 0, 10, 30% of functional capacity and get them back up to 90%. But there are some things we have to consider when deciding fixed, especially with implants. Number one, do we have enough implants placed? Where are they placed? Do we have enough AP spread? What about vertical dimension? Fixed case requires quite a bit of vertical dimension. Is there 15 millimeters? I can tell you in our design center at Preat, in our Prism Center, we don't follow this guideline. We try to, but sometimes patient has expectation of fixed teeth. We have to get creative in what we can do to provide fixed teeth. What about patient dexterity? Fixed restoration takes a little bit more work to keep it clean for hygiene maintenance. This right here is something we would not want to see. And I'm glad that you guys are in at 10:30. This is probably the worst photo I'll show, but at least no one's ate yet, I hope. What about the smile line? Do they have a high smile line, medium smile line, low smile line? Why is the smile line important? We have this thing called the prosthesis tissue junction when working with fixed cases. It's the junction basically between gum tissue or soft tissue and the prosthesis. We do our best to keep it convex or flat in shape for easy hygiene maintenance. And the implant must be placed higher than the smile line for proper prosthesis tissue junction. Patient presents in a media case where the implant's going to be placed. That means the implants are placed there. The highest prosthesis tissue junction we can have is this line here. So does the patient's smile line allow for this type of restoration? 4 types of prosthesis tissue junctions. You got the ideal or convex surface. You got the acceptable, that's a flat surface. Then you get into questionable with a little bit of a ridge lap or modified ridge lap. And then what would be deemed unacceptable is a complete ridge lap. So the gingival transition line or prosthesis tissue junction must be out of the aesthetic zone. This is acceptable. So now that we've taken patient considerations into place, we know patient can have a fixed restoration or should have a fixed restoration, I should say. Implants are placed. It's time to pour up, or take that impression, pour it up, take a look at our cast. Case comes into the lab, model's poured up, you got this beauty. Next thing, well, let's see what the prescription says. Oh yeah, patient has the expectation of fixed teeth. All right, it's time to make life interesting. So, at this point, kind of feel a little bit like this. This was at our old office in Grover Beach, California. It's where you can go right out on the beach and drive around in the sand dunes. So in this situation, you have your dentist here, who got stuck out there, calls the technician, also got stuck. So where do you go from here? If anyone wants to know more about this slide, come see me at the booth. I'll tell you the whole history of it. But really happened. Guys probably shouldn't have been driving Fords. So from here, I just happen to have a Chevy. I think Fords look nice. I just got a clown. I know those drivers. So the provisional restoration is where we go from here. Converting the patient to provisional. Implants are placed. This is the traditional method, or using an immediate denture. In the mouth, the temporary cylinders are luted to the provisional. And I love this method right here of doing a suck down beforehand. So you got a clear stint you can take to the mouth, identify the implant position, and then mark that on the suck down, rather than taking either a quick wash or just going in and coring out the denture, not knowing where those cylinders are. That suck down's put back on the immediate denture. Denture's cored out where the temporary cylinders are going to be luted to it. Intraorally, the cylinders this is using chair side, any self-cure, light cure material will work. Denture's transferred back to the model. Palate will be cut out, flange will be removed. And now we have a provisional restoration that the patient can have for a period of time and get used to their fixed teeth again. So provisional restorations, to me, they're a communication tool. They're a communication tool from the patient to the whole restorative team. What they like and dislike about the restoration, how it feels, is occlusion right, comfort. Remember, this patient might be missing their teeth for a period of time, so they've got to adjust to having fixed teeth again. On to the definitive restoration. Foundation's key. In an analog method, we'll pour up a soft tissue master cast, do a verification jig, and have the approved wax setup. Verification jig, always, always, always need to use titanium cylinders. I will explain that titanium will show up in a radiograph. In the last 10 years, we've had one bar that we know of where the master cast was verified, where it didn't fit in the mouth. So again, all the problems happen to come from local people. I don't know what it is around our area, but a local technician gave me a call one day and said, hey, the bar you guys did, after I processed the teeth, doctor went to seat it, it didn't fit in the mouth. I said, but Tim, you sent us the verification jig and it fit the model. He's like, yeah. So I'm thinking, what could possibly go wrong? So I asked him, when doctor seated the verification jig, do you have any x-rays of that? Silence. So when doing verification jigs, I recommend always take radiographs to make sure it's fully seated in the mouth if the implant or abutment is sub-G. Quickly going through the verification jig, this is using a light cure resin. It's molded around the temporary cylinders or non-engaging impression posts. When making the verification jig, please, please, please always make sure the abutment cylinder interface or implant cylinder interface is clear of any acrylic. This makes it easy to see the connection and is fully seated. Verification jig will then be transferred to the mouth, and one by one, basically the Sheffield test is done in the mouth. Doctor will take the the guide pins or screws, thread them down one by one, watching for any movement. If there's any movement, section that implant part from the jig, have doctor elute it intraorally. Two things you could do at that time. Doctor could either take an impression, an open tray impression over the jig in the mouth, or send the jig back, the adjusted jig, to do an altered cast. Either or. A couple other cool techniques with the setup or jig. You could do a verified setup. This is using the verification jig, and the teeth are placed right over top, seated down in the mouth, screwed down so you know that setup is right where it will be once it's processed or completed, or directly over the verification jig. Simply doing the wax setup, teeth over the verification jig. So the fixed detachable or traditional screw retained fixed restoration. Some of the advantages: you have increased prosthesis stability. They're fixed teeth, and remember, patients want those fixed teeth. You have abutment splinting, maintains bone, open palate for taste and comfort. I said I'd talk about my mother-in-law. She's the other person that I know that has dentures. While I love to hear her complain about things, the one thing I actually hate to hear her complain about is the fact that she cannot taste food. To me, that's just extremely sad. And that's the one thing she misses most about having her dentures right now with full palate coverage. Other advantage to a fixed restoration is aesthetics. Some of the disadvantages, though, it's going to require more implants than some other treatments, or longer implants, which means cost. You cannot independently service one of the implants. Patient loses an implant, what do? You have the hygiene aesthetics trade-off. Great aesthetics, but hygiene maintenance is going to be more difficult for your patients. They're expensive. Phonetic issues in the max is common, especially when we don't have a seal to the tissue. Flanges can be unhygienic, as we saw earlier, with the different type of ridge laps. And wear or breaking can be a major problem. The first type of restoration we'll look at is acrylic denture teeth processed to a titanium bar. This type of restoration we call the wraparound technique. It's ideal in the maxilla. This is especially true because you can reline this case as intraoral conditions change. But it does require more space than some of the other fixed options we could look at. So again, we got a titanium bar. We're going to design underneath the setup. Acrylic will be processed over with denture teeth afterwards. Talk about space, what's required for this type of restoration. Looking at, we need about 1 to 2 millimeters. That's for our acrylic wrap underneath the bar. About 4 millimeters for titanium. Another 2 millimeter acrylic wrap under the denture tooth, and about 4 millimeters for tooth thickness. That adds up to about 12 millimeters minimum that we would need for this type of restoration. Oh, it's a great thing all fixed cases look like this, where we have 21 millimeters of space. I wish. Never happened. It's only happened one time in our design center that we had this much space. And I had to get photos of it and share because I don't know how many other people see this often, especially without any bone reduction. So you have all this space, that's great. We could throw any type of titanium bar in there. This photo actually was about 12 years old, and this is what we used to mill out. This is what the technology at the time allowed for with the mills we were using. But sometimes space is limited, that 14, 12 millimeter space, so we got to get a little bit more creative with our design work. This guy that did this doesn't work for us anymore either. So when designing, we scan in the soft tissue set, or the master cast, the setup over top. That allows us to know all the space we're working with for this restoration. It allows us to design the bar in the optimal position to provide acrylic thickness and space for the teeth as well. So in this case, you can see We have about 8 millimeters from the crest of the ridge to the cingulum of that denture tooth. That gives us 2 millimeter space to wrap around on the tissue side, about a 4 millimeter thick bar, and another 2 millimeters of acrylic thickness before the denture tooth. Facial aspect, you can see the person we were designing this bar for liked to have some additional mechanical retention, so we got the little nails going up into the denture teeth to prevent them from popping off. And this type of restoration, because we give adequate space for the acrylic wrap, and we have adequate space to begin with, allows us to finish this case once the acrylic's processed with a convex intaglio for easy cleaning or hygiene maintenance. Problem is, we don't always have that type of space. This is a more common case that we see in our design center. And I think that was about 6-7 millimeters of vertical space from the crest of the ridge. So in this case, the ideal restoration type would be the Montreal or polished metal on the intaglio, so we don't have to have the acrylic wrap. So it's easier for patients to keep clean versus the hybrid. Doesn't harbor bacteria on the metal. The frame design actually leads to more acrylic support from vertical load, and it's ideal in this type of situation, 9 millimeters. In fact, we've had cases, which unfortunately we've done, where you can see the cervical of the denture tooth is actually lower than the crest of the ridge. Those are tough cases. So we have to look at it from a space-saving design. So we talked about 4 millimeters of vertical titanium with a wraparound. Because we could make this wider buccal lingual when we designed the bar, we could shorten the vertical height down. We've taken designs like this down to 2.5, 2 millimeters in total vertical height of the titanium. We could design the tissue side to be completely hygienic. You can see the complete convex tissue side. Easy for the patient to get underneath the bar, keep it clean. And we have adequate space for acrylic. So we still have to maintain adequate space for acrylic because acrylic gets its strength from its thickness. So just because we put a titanium bar or in an overdenture a piece of metal mesh in there, we can actually be weakening the acrylic because now it's not as thick. So the acrylic can still break off. So when we do designs, we still like to maintain 2 or more millimeters of acrylic so the acrylic is still strong under load. You see here in the mandible, designs can be done where they don't have to be on the tissue. No one's going to see that. There's no smile line. It's not required. It makes it easy for the patient to clean underneath, maintain hygiene. Smooth lingual surface, nice finish line, gives a great junction between the acrylic that'll be processed to the titanium bar. It's comfortable for the patient. They're not going to feel an irritating surface and sit there and tongue thrust the back of this new restoration. And again, all while maintaining acrylic thickness. Another thing, though, that we like to do is we'll actually remove the teeth from the setup before we scan it in. This is for people who do not want to alter a denture tooth at all once they receive a bar back. And we've had the issues in the past. We do a beautiful bar, but what we can't see when we scan teeth or denture teeth in a wax setup is where the actual denture tooth is. The bottom part of it, the intaglio side. So we do these beautiful bars, send it back, they transfer to the bar, and they said, I had to adjust my denture tooth. This is a way that you can provide titanium bars for these type of restorations, making sure that the denture tooth does not have to be adjusted when it's transferred to the titanium. See complete acrylic thickness, knowing. And I showed that fun titanium bar earlier. These are the kind of capabilities that milling machines are producing today. This has come a long way. You see complete polished lingual intaglio, finish lines for the acrylics. This is what is able to be produced to provide these final restorations. This is the foundation for the beautiful acrylic and denture teeth work that'll be processed to this bar. So as an example, Here's a bar we designed. Again, another local technician. His name's Butch. We'll talk more about Butch later. This is after he transferred his denture teeth to the bar with wax. You can see the vertical space and why we had to produce such a small vertical bar. And the final result after processing and finishing. Seems like a happy patient there. Do all kinds of different designs. Metal occlusion for the patient that keeps breaking some denture teeth off. You have the individual prep design. Design each one for zirconia. Process either acrylic or porcelain. You can stack porcelain in the tissue area. Lingual side, polished lingual. And finally, the finished result in metal. This is the only time I have ever seen this in a case, but I find it really interesting, which is why I like to show this one out of some of the other designs we've done. Right in here, looks like we screwed up something pretty bad. It's actually the angle of the implants. They were angled in opposite directions, so in the structure they actually crossed. This is kind of neat, different things you see every day from different patients. Again, final restoration. We get a lot of unique cases. This is another one. They decided to do a couple zirconia crowns to hold vertical dimension, not wear down denture teeth. Process denture teeth in acrylic for all the others. So a lot of different designs, different techniques. Again, knowing the patient, knowing maybe parafunctional habits will determine what's the ideal design for the patient. And then you got the patient you can't prepare for. So what do we do with this guy? Well, first we got to treat our headache. You know, we got the migraine, stress, hypertension, and oh yeah, this patient just walked in, the dentistry headache. Real cases. I'll say it all the time. I know we can look at a model, we can look at it and say, oh, what was this guy doing when he placed these implants? I don't claim to be a surgeon. I'm not a surgeon. I'm not a licensed dentist. All I know is those implants were placed for some reason, somehow, and it's our job to figure out how to meet the expectations at that time. So rather than saying, just send it back, they have to have new implants placed, let's get creative. Let's find out what we could do. So introduce you to Mrs. Jones. Mrs. Jones presented at the University of West Virginia with this restoration. This is a fixed restoration. Mrs. Jones had 5 implants placed and then was given a fixed restoration. So she probably paid quite a bit of money at a private practice before she showed up at the university. And this is what she's going around, not showing her friends, not living her life to the fullest. So how could we change Mrs. Jones' life? Another shot here. So some people might say, were multi-unit abutments used, anything like that? I can tell you the implant type that was used here does not have an angled multi-unit abutment. So that was out of question. So we decided what we were going to do is use an angle screw channel in the titanium bar. So this is a way we could design a bar and bring the screw access channel back for those implants 30 degrees. It's all done between the way the driver engages the screw head. It works as like a gear. I like to think of like a big clock, like Big Ben. You got this horizontal gear turning a vertical gear. That's how the driver engages the screw. So it gives us the ability to take that screw channel that's coming out in the aesthetic zone and move it back into an ideal position. In the design software, you can automatically see the difference of where the screw channels would be with the white access channels and where they're corrected to with the gray access channels. And that allows Mrs. Jones to get a life-changing restoration. So this is the wax and teeth transferred to the bar we designed. You see the bar design, you can see the access channels are on the lingual finish line versus the facial that they were coming out before. The opaque's done, completed. A little bit of tissue where we're going to process acrylic. White where the denture teeth are going to be. And Mrs. Jones' new restoration. This right here, where it was a challenge at first, this is where I feel most rewarded in what we do in this industry. When you could give Mrs. Jones, who lost something, was given something that she thought would look a whole lot better, but then the final result. That right there makes it all worth it for me and what we do. Yeah. Mm-hmm.
Use 4 of them to hold the prosthesis in place and just let it rest on that one and leave the screw out completely.
I agree. We've done that plenty of times.
We call it sleeping the screw.
I like that. Sleeping the screw. Yeah, we do it. We actually design the bar where it's solid too, that you can't even put the screw through there.
And we leave an access hole for once it's needed.
Gotcha.
Process over.
Okay. Yeah, we've done it plenty of times. In this situation, so again, where I don't claim to be a dentist, sometimes I have to work under a prescription of a dentist, which will be a fun case to look at later where they wanted to use all the implants. But yes, I agree, that's a great solution, especially when you have enough implants for it. And so there's Mrs. Jones with the restoration. So anyway, enough about acrylic and denture teeth. Let's talk about zirconia, or the digitally designed full arch. We'll talk a little bit about digital dentistry as a whole. We look at, outlooks of the future, digital workload. Digital crown and bridge is booming right now, 24%, say. In the next 5 years, it's only going to keep going up. Growth of digital impressions in crown and bridge. There's a few full arch scanners out there now. The technology is only going to improve. These edentulous patients, we might not see traditional impressions anymore. We're going to see digital impressions or intraoral scanned patients for these full arch cases. So this is where we stand. We've been doing digital dentistry for 20 years. Always like to thank my mentors who have helped me in life to get to where I'm at. One of them was our founder at Preat, Tom Bormas. One of the best lines ever at a trade show that I heard talking about. We were talking about a fiber product that we sell. He's talking to somebody, and the guy said, well, I have my old material on the shelf, and I'm going to use that before I order some of the new material, the new generation. And Tom, being Tom, was a great guy, if you guys know him. Not, but he pulls out his phone, and he said, yeah, I used to have an old phone that worked just fine, but this new one does a whole lot more things. So it's kind of a way we look at it is how we look at dentistry. There's ways to do it in the analog way, but there might be ways to do it that's more advanced in the future. And right now, I personally am trying to eliminate digital from my vocabulary when talking about dentistry. And my justification for that is 20 years of doing it one way almost becomes somewhat of a standard. So again, an example with a cell phone to that would be 20 years ago, I might have called this a cell phone, but today I just call it a phone. So it's just dentistry. It's no longer digital. You look at it. Is this a digital model department or just a model department? Both of these guys are technicians. There's a whole lot we could do in digital dentistry that we do in analog dentistry. Full dentures, partial frameworks, crown and bridge work, titanium bars. Seems like it's endless. We do anything we can think of in a digital world. Is it true in implants? Maybe, maybe not. Implants have one limiting factor when it comes to a digital world of dentistry, and that is to pick up the implant position, you need to use a scan body. Well, scan bodies are tied to certain libraries or options you have to work with. Some of them don't allow for the choice or selection of the part you may want to use for your restoration. So 2 years ago, during 2020, we had a lot of time on our hands in March, April for some reason, and we decided we were going to design our new implant library. And I was talking to a few friends of mine in the industry and was just telling them, hey, we're going to take on doing a new library for implants. You know, what are your thoughts? This is where we're at. And it was really interesting talking to people working with digital libraries because they're saying, well, I don't have this in my library. I don't have that in my library. Why not put your temp cylinders in the library? Why not put this component in the library? You can put anything you really want to in a digital library and use it. So that's how we came up with what we call our choice library. We basically took all the implant parts that we offer and threw them in a digital world. So for implants, where you have your scan body for, say, your Zimmer or Nobel Active implant, you have 17 different restorative options for these cases, for these patients. You can provide your dentist with an OEM style screw. If you need to correct an access channel, you can do that. If you need a taller tie base, you can use a 9mm tall tie base. And then the temp cylinders, of course. I know a lot of people do a lot of restorations with temp cylinders. A lot of people mill a lot of PMMA provisionals. There's not a lot of mechanical retention to a tie base. You can have that with the temp cylinder. On the multi-unit level, same thing. 9 different parts and pieces you can choose from, depending on how you're designing the restoration. Also, you have your choice of what screw style. There's a lot of multi-units that now are prosthetically compatible to each other, but if your dentist is a Nobel dentist, you have the Unigrip driver or Unigrip screw. If they're a BioHorizons dentist, they're using an 050 driver. 048, 3i, Hyosin, Megagen, SRA, Straumann, whatever screw you need. All the parts, pieces come with it. Angled access channel, you have the short one, the 9mm tall, that can be adjusted down to 7, 5mm. And temp cylinders for multi-units. So it offers flexibility. I'm not here to talk about a specific workflow. You guys all have your own relationships with your clients, with your dentist, right? You have found a way that works well. Now we're just giving you tools to add to your toolbox. Doesn't matter if it's an analog impression, a digital impression. We looked at a verification jig earlier. Why not do a digital model in verification jig? You do that with the digital analog. So doctor takes an intraoral scan. You design the model. It's tapered, so it's self-guided into your 3D printed model. There's one solid flat surface, so it won't rotate once it's positioned in the printed resin, and 2 vertical stops. Lastly, a security screw. So after you print your model, design your model, analog slides in the void that's printed, security screw tightens it in place. Model's printed. Yeah, so currently we have these type of analogs for 18 different platforms. We will be expanding that for 13 more platforms in the second half of this year. And that includes the multi-unit one too. So for full arch cases, do a preliminary scan, print the model. You can use one of the bar modules in the temp cylinders to 3D print a verification jig. Verification jig sectioned on the model, sent back to the dentist. Now, he can lute those pieces together in the mouth and do an open tray impression right over top, and you got a verified impression. One less impression that the patient has to sit through. Provisional we looked at earlier. Well, we do provisional with our design software using the temp cylinders. So was everyone in here for Tim earlier, Tim Torbenson? Okay, I've been living in his world for a while. I'm also in charge of our quality assurance department at Preat right now. And what's interesting is people believe that you can't use temporary cylinders for a final restoration. And I can tell you, having filed 510Ks for all these parts, that there is no difference between a temporary cylinder and a tie base when it comes to material or classification by the FDA or in the indications for use that's required. The reason they call it temporary was the type of materials that were used for them originally, resins applying to them. That's why they have mechanical retention. You can.
I may agree with you from the standpoint of your product.
Uh-huh.
I can still tell you that some of these titanium cylinders, temporary cylinders, different manufacturers fracture very easily.
Titanium?
Yes.
Ooh, that's
They
bad.
usually fracture right above where the screw, where the head of the screw is.
Uh-huh.
Fracture laterally.
Really? Can we talk about that afterwards? I'd love to learn more about that. That's very, very interesting, especially titanium. I can see it out of PEEK or,
It's because the retention grooves are built so thin.
so the sidewalls are breaking. Got it. They might not have done their fatigue testing. So you design your restoration, multiple heights using the temp cylinders, provisional. This is just showing the fit after the mill. You'd of course use some acrylic to lute it to the PMMA. This is another advantage of the way we've designed the library. It's one physical part, but you have multiple height options in the library, and you just manually adjust the physical components using a diamond disc or any other cutting disc. So temp cylinders, you might have them in stock for your all-on-4 cases. You might have areas where you have less vertical height. When you're designing, you design with the shorter options, then you just cut the same part. You see in the design software where you may want a shorter cylinder or tie base versus a taller one. And the provisional and the seating surface. So, like patients, implants are the same. No two implants are ever placed identical. No two implant patients are ever the same. That's where the versatility of the angle corrections come in when you're using tie bases. You have the option, once you're in the design software, to see where the screw access channel is to the ideal restoration and where you need to actually position the access channel. And this angled access channel option, or dynamic, allows you to move the direction of the access channel 30 degrees, as well as 90 degrees mesial distal from where the tie base is. Way it works, screws placed in the access channel, driver engages it, driver threads the screw down, much like a gear. So patient scanned in, see the position of the access channels, it's not looking ideal, using the proper tie base in the library, you just move it back 30 degrees, or how many ever degrees you want to put it in the ideal position. You see it on a model, the difference you can achieve on these cases. Pretty much all of them. Yeah, so we have the full options of the tall ones you'll see in a minute and the short ones in the digital library that we designed for the same 18 interfaces right now, and we'll be adding more. But overall, we have other library options for pretty much all interfaces on these. Another shot here. See, this was a provisional. We could see the denture tooth that was being used and where the access channel will be on this case. This was the final restoration or definitive restoration for that case. It's completed by Bill Murray. And one of the things Bill taught me with using angled access channels, especially on full arch cases, if you're going to use one, it's best to use them on all implants. The advantage is the dentist in the operatory doesn't have to look for a different driver. And there's also one other advantage in the posterior. So posterior, we might not be worried as much of the screw access channel position, or might be in a more ideal position already. Well, you can still angle the access channel back towards the tongue or palate. And what that does is that allows the driver to have more space intraorally when connecting the driver and torque wrench. So just another awesome tip that Bill taught us. We looked at different vertical height options earlier when we're looking at titanium bars. This is the 9mm tall option. You can see it's identified at 7 as well as 5. So you have one tie base, and you have 3 heights that you can use this for. In the design software, cut it down to either 5mm if it's a short tooth, 7mm, or 9mm. Multiple options in the same case, just all patient dependent. How much vertical clearance do you have? One thing I'd like to point out though is how the libraries are designed. Everyone believes that the access channel should be angled right at the cutout of the tie base. That wouldn't work on a 9mm. If your access channel's cut out here, your milling machine would have to cut a very thin area for the remaining tie base. The other reason for that is how the driver actually works. I don't have a full section in this presentation, but this extra area where there's no tie base, but it's milled out, the void's milled out in the zirconia, actually allows the driver to work properly. Because the driver, the screw head's gonna be about this height when it's placed on the implant, and then you gotta thread the screw down. So the driver will engage at a certain angle, and as it goes down, the driver actually moves. So that's why it's designed this way. And that's why the access channel won't come out directly at the cutout. So, 9mm tall tie base, cut it at 7, 5mm depending on the restoration. It's the case here in the posterior. Implants are placed at different levels. 7 was used, a 5 was used for this case. And really what it's designed for is prosthetic control. You know, same patient, different result, depending on what parts and pieces you have in these libraries. You can see right there, there's an access channel right there coming out of the cusp tip. This was used with straight access channels prior to, and the final result using angled access channels or the dynamic option afterwards. Another fun option we have in the digital world of dentistry. This is a provisional This was done by a good friend of mine. He actually spoke for us in Chicago. His name's Jose. So he uses the reverse scan bodies, or scanologs, as we call them, and he uses them on a provisional. So he actually does a zirconia restoration in 48 hours for immediate placement. And how he does this is after placement, he gets an intraoral scan, designs this provisional, shows it to the patient, finds out, gets patient acceptance, but we can see, got that problem here. He then scans this using his Medit scanner, and he goes back in, designs the final restoration, and he does that using the angled access channel option tie basis. And he's able to deliver the zirconia restoration in 48 hours for these patients. I will say, this technique of the scanologs, the two main softwares, exocad and 3Shape, do not make it very user-friendly. We've done a lot of testing, but if anyone wants to talk to me, we can talk about the workflows necessary to use them. exocad's a little bit easier than 3Shape for this type of approach to these cases. And the final result, this is just showing the provisional with the straight access channels to what he's able to achieve using the dynamic or angled access channel option. Last type of fixed restoration we could look at is the fixed removable. This is still a patient fixed fill, but they can remove it. So you have increased prosthesis stability because we're going to use a bar, an overdenture bar. It feels fixed to the patient. You have abutment splinting, maintains bone because of the implant placement, open palate, again, my mother-in-law. Aesthetics to restore lip lines. We talked about the prosthesis tissue junction. So this is a case we're going to do an overdenture over a bar. It's still going to feel fixed in how we attach it to the bar. But this is for those patients who may have a high smile line, where you would be able to see that prosthesis tissue junction. You can do this with an acrylic flange. Or maybe it's for the patient who didn't have implants placed right away, and they have bone loss now. And now we need to restore using a flange for muscle support of the face. Give them that youthful appearance back. Easier hygiene in comparison to a fully fixed case because the patient can remove it. Like all fixed options, it's going to require more or larger implants. It's going to be a little bit expensive in comparison to a 2-implant removable case. Patient can remove it. That's an advantage and disadvantage. Maybe the patient doesn't want to take it out and clean it. And we achieve it by using an overdenture bar and a plunger lock. So the bar supports prosthesis. Patient uses their fingernails to activate the pins and push them into the bar. Once the pins are pushed into the bar here, that's locked in. There's no lift, there's no movement. It is not resilient. And so since we were talking about fixed in today's time, that takes those patients, again, with no denture teeth or lower denture, upper denture at those functional capacities, back up to a 90% functional capacity. There's a couple of different ways you can design the bar itself. This bar was designed with one anterior hater clip, and it's a 4-degree tapered bar, and the secondary was cast right over it with that same 4-degree taper. So you got a full friction fit of the bar to the prosthesis along with the plunger lock. These are the locking pins here. As you can see, the one on the left is in the closed position. The one on the right's open. They're titanium, so they're processed directly in the flange of the acrylic. They could be cut down. They come in a total length of 7.5 millimeters, but you could cut them down to 6, 5, 4 millimeters, depending on how much thickness you have in that buccal flange. In open, closed position. As you're processing the case, you wax the plungers into the buccal flange. Here's the case and the flask. These are the processing jigs to create the hole in the buccal flange. And afterwards, we're going to position the plunger. We might have to cut it down in this case. The photo you see here with the soft wax, that's because we know that plunger opens and closes. That wax is sealing just that little gap area where it moves, so no acrylic gets in there and locks the plunger in a frozen position. This was using self-cure acrylic just to tack the plunger into the flange. And now you have a finalized case where it might look removable to everyone else, but it still feels fixed to that patient. So it's another great option for some of these patients that desire fixed teeth. It might not be the ideal candidate to have a screw retained restoration, but you can still give them what they're looking for, what they want. All right, as promised, the fun case we started off with. This was a case, 6 implants. This is a real case that we restored. We talked about maybe sleeping some implants. Patient wasn't going for that on this. Patient paid for 6 implants. They wanted to see 6 implants used fully. And those 2 in the anterior there, those already have a 30-degree multi-unit abutment on them. I don't know how or why they were placed that way, but that's what we have to work with.
Do you guys make a 45-degree abutment?
We do not, and again, it's because we haven't done the proper fatigue testing on that. There are companies that have 45, and I've seen even 60 degrees. But I could tell you these do not. I've seen the 60 on most external hex cases for the zygomatic implants. So 30-degree multi-units placed, 6 implants. This is how we solved this problem for this patient. So we created a primary bar here on the 2 implants to pull everything back over the crest of the ridge and the 4 remaining implants. Then we designed our titanium bar that we're going to process acrylic to have a void that goes over that primary bar. So the 4 will be threaded straight down to the implants. They'll seat directly over the bar. And we created this little pilot hole that you can see is tapped there. So it actually has a lingual set screw connecting to the primary bar there. So it's a fully fixed option this patient is given. It's what they wanted. It's what they presented with. It's what they're going to get. Another one, the inherited case. I promised to talk about my friend Butch. This is Butch's case. I love Butch. He taught me a lot. You'll see some things about Butch's case, but one thing Butch is really good at is communication. So this patient, this is probably their, I think he told me at this time, their 4th fixed restoration that they've had. 3 had already previously failed. Reason for failure you can see is a deep bite and probably the design of the fixed case previously. So I promise Butch is good at communication. Butch wanted to do metal linguals and metal occlusion in the posterior. So he provided us this setup, and everywhere it's green, he wanted us to have metal finish. So we designed it, put the metal finish in, the design, you can see all this solid yellow area. This will all be polished metal. Gave him adequate space for his restoring materials. And Butch is a little bit of an old school technician, so he likes mechanical retention for his acrylic he processes. So he challenged us and told us we had to put a whole bunch of holes through the spiggle structure. So when he processes acrylic and injects it, it's fully locking, it's never coming off. This is the design we worked on with him. Holes for all the acrylic to be processed through. Butch opaqued the case, transferred his teeth, and this is the final restoration Butch delivered to this patient. This case has been in the mouth 5 years and has not had any failures yet. After, it's only the 4th attempt. So, but Butch understood the patient's expectations and also the patient's concerns. He gave us good communication of what he wanted to see, and we were able to help him deliver this life-changing restoration for this patient. So, with that, we're going to end a little bit early. So I just wanted to talk a little bit about unique ability, and that is when passion and talent acts as a core focus. And for me, my passion is changing people's lives. My talents, I would say for something like this, are knowing the various options and understanding the patient. And when I use those two and they act as my core focus, that's where my unique ability comes out. It's these cases that look like nightmares, that look like challenges, and my wanting to help these patients and thinking outside of the box, knowing what's available and helping them. So with that, thank you. I appreciate the time, and go to lunch. Thank you.